Welcome to this edition of You and Your Health. My name is David James. The topic of today's discussion is reflux. This is an annoying condition that many of us have experienced, especially after a heavy meal at night, resulting in much gastric discomfort and loss of sleep. Many of us have also experienced this discomfort during the day, resulting in a cabinet full of antacids. We have with us Dr. Robert Sipzener, a board-certified gastroenterologist who has practiced for many years in the Boston area. Thank you, Dr. Sipzener, for being with us.
Thank you.
Would you please tell us what is the specialty of gastroenterology, your particular medical background, and what training did you have to become a board-certified gastroenterologist?
Well, the training in gastroenterology. Gastroenterology is a topic that involves the gastrointestinal tract, and we also spent a lot of time with hepatology, the study of the liver. I went to medical school at the State University in New York, Downstate Medical School, and then did my internship and residency at St. Vincent's Hospital in the Lower West Side of Manhattan, and the training in gastroenterology at Strong Memorial Hospital, which is part of the University of Rochester. Since then, I have had a large gastrointestinal practice at the Boston area and south of Boston, having affiliations with hospitals in Boston and south of Boston.
Would you please start us off by describing to us what is reflux?
Reflux is a problem that we have where the acid, bile, pepsin, food within our stomach comes up into the esophagus and sometimes goes through the esophagus, actually up the esophagus, above the upper esophageal sphincter, into our lungs or into our mouth. It's an extremely upsetting and annoying problem, and it is a problem at many different levels. The first problem is that of the fact that it can cause us to be very uncomfortable. It can wake us up in the middle of the night with what we call nocturnal reflux. Part of the differential diagnosis with reflux is that of cardiac disease and anginal symptoms. And one has to be very careful that we're not missing a diagnosis of coronary artery disease when in fact we think it's reflux. The other problem is it's associated with a disease entity that we call Barrett's esophagus, which is a chronic inflammatory state within the esophagus. And that has an increased incidence of esophageal cancer. The most troubling part to me is the fact that patients frequently treat themselves. As you said before, they have antacids in their closets. They have different medications that they can buy over the counter. And as a result, the diagnosis can be missed. And we could miss something that is of more significance and that could be catastrophic for the patient.
Is that present in all age groups, both men and women, or is it a more propensity for one sex versus another?
Anybody could have it, but it's found mostly in men. It's found mostly in men over the age of 50 years old, and in particular in the Caucasian group of men. But again, anybody can have it. It's associated with people, as an example, who are obese, people who eat large meals and in particular go to sleep, large fatty meals. There are many different things that can help precipitate this. And as a result, the people that get this are people that have problem in terms of what they eat, how they eat, their size, the fact that they wear tight clothing, the fact that they're on certain medications, anticholinergics, calcium channel blockers, aminophylline. These medications can make reflux worse. There are so many different things that can precipitate reflux problems, but again, it can be associated with other diseases, and we don't want to miss more important abnormalities by just blowing this off.
Is GERD, gastroesophageal reflux disease, is that synonymous with reflux, or is that a more advanced type of?
No, it just means they're synonymous. It just means gastroesophageal reflux disease. It's just the acid or pepsin or bile going up into the esophagus causing discomfort, or sometimes not causing discomfort.
You mentioned Barrett's esophagitis. Is that a long-term complication of GERD, an untreated GERD, or is it a separate condition?
No, it tends to be a chronic inflammatory state of the esophagus. And what happens in Barrett's esophagus, we call it intestinal metaplasia, with chronic inflammation of the esophagus. One, in fact, gets inflammation. Our body then attempts to heal it. Most of the time when acid goes into the esophagus, peristalsis pushes it out, or pepsin, or bile. Peristalsis tends to push it out. And we have saliva, which tends to neutralize it. But if we, in fact, have a lot of acid go in there, it can even cause more significant problems where it goes up, again, into our lungs and things like that. With Barrett's, you have chronic inflammatory state. And what our body attempts to do is we have in the esophagus squamous epithelium. The lining is squamous cell. In the stomach, we have columnar epithelium. The columnar epithelium is much more resistant to acid than is the squamous epithelium. So we find a migration of the columnar epithelium into the esophagus to help protect the esophagus where we have had breakdown. As a result of that, we get this state called Barrett's esophagus. And in fact, what happens is you have what we call a Z-line. The Z-line is where the squamous and columnar epithelium meet. This can migrate up. And if it migrates up within, let's say, 2 centimeters, this is called short segment Barrett's. If it migrates up more than 2 centimeters, it's called long segment Barrett's. The problem with this is there's a propensity to develop malignancy with Barrett's esophagus, and it's got to be carefully watched. Now, you have to understand that reflux disease is extremely common. In the United States, in BallenIsles, 7-8% of people have reflux every single day. 15% will have it once a week. 40 to 50% will have it once a month. So this is not an uncommon problem. It's an extremely common problem. In fact, when the proton pump inhibitors came out some years ago, Prilosec, which was the most popular and the first one to come out, was selling over $5 billion of its medicine a year just in the United States. So again, we have this medication that people used indiscriminately, we'll say, at least now, and use it frequently because of its effectiveness.
Now, with so many people with reflux disease, what percentage will develop Barrett's esophagitis?
We can break that down in different ways. When you have Barrett's esophagus, short segment Barrett's esophagus, 20% of the people that have gastroesophageal reflux disease will develop short segment Barrett's. 1.5% will develop long segment Barrett's esophagitis. If you then look at the people with long segment Barrett's esophagus, 0.5%, 1 out of every 200, will develop esophageal cancer each year. Now you say, well, that's not so much. If you compare it to the general population, it's 30 to 120 times the amount of esophageal cancer that the general public will have. So Barrett's esophagus can be treacherous and needs to be watched carefully. And if there's one message today that needs to be given, and I'll probably give it more than once, it's if you have reflux and if it's a chronic problem, you need an endoscopy. You need to have this looked at. You need to be sure that you're not predisposed to this type of problem.
So it's not just go over to the medicine cabinet and let me swallow a couple of acid neutralizers and
Exactly. The problem
go
that
take a look and make sure that you don't have anything more complicated.
Exactly. If we determine that you have Barrett's esophagus, we take biopsies. When we take these biopsies, we look for dysplasia. If you have low-grade dysplasia, if you have no dysplasia, that's wonderful. You need an endoscopy. If Barrett's comes back, you repeat it in 1 year. If it comes back again, no dysplasia, every 3 years. If you have low-grade dysplasia, it's every 6 to 12 months. If you have high-grade dysplasia, it's every 3 months, and your chances of developing esophageal cancer are 20%. So you're dealing with a high predisposition to getting a very bad disease.
Well, Rob, we're running out of time for such a really very common problem that can have severe complications. But we thank you for being with us, and we look forward to seeing you maybe at some other time and do some other parts of our gastrointestinal tract.
That would be my pleasure.
Thank you for being our guest, you and your health.